Hey everyone, and welcome back to the Dr. Eric Fethke channel. I'm lucky enough to be joined today by Dr. Eric Fethke, a pediatric cardiologist and the writer of The Pursuit of Health. Eric, how are you?
I'm well, thank you for reaching out across the pond.
No, well, I wanted to have this chat, particularly around the cost of medicine. So, you've said in the past that there's room to believe the cost of medicine is being kept intentionally high, or at least that the current incentives keep the prices high. What is going on here?
Well, I think the incentives are wrong. We built a system initially in which the focus was the patient. We come back to this idea and try to make it sound like it's new and novel, patient-centered care. But I mean, if you think about it, that's a little ridiculous. The entire system was always based around the patient. The doctor wasn't out there, saying, "Okay, let me look where I can make the most money." The patient. They were always focused on providing the care. And historically, as I talk about in some of the background of my book, we kind of were very autonomous individuals, kind of took care of their own health, especially in rural communities and other areas, and especially if you didn't have means. But as technology got better, we were able to do things. There started to becoming more of a cost to health care. And as we did that, we started needing to fund that. And there, the business model changed. I mean, that's way back. We're talking about, literally in the 1800s. So we start building facilities and then people to run them and the doctors to work in them. And you get this symbiosis of a system. But that system, comes with a cost. We get better care. We start advancing the technology, but it's not free. And then the question is, did somewhere along the way, and I believe we have, did we forget the patient as we started creating a system that was more technologically bound, and we're heading there again in many ways, more infrastructure bound? And did we turn around and go, where's the patient? Are they here in the operating room, in the exam room, in the community, in the discussion? Are they still part of the center? Or are we still focused more lately on the money than trying to help the patient? And I know that's not true necessarily for everyone involved, and not trying to make a blanket statement about this as an evil empire, so to speak, doing this, but it's the way the system runs, and we all have to work within that. And I think that's a big issue that we have to be honest with in this country, that the money has gotten in the way.
It's interesting because there's this divide between more healthcare and better healthcare, and more you can charge more for. You're providing more of a service, but the incentives seem to have come apart at the seams.
Right. Yeah, you've got this thing where I have this image when I was interviewing for pre-med. Even it wasn't even for I was in college. I was uh, looking at colleges and trying to interview for medical programs. And I walked in thinking I knew everything, all the answers that were going to be asked currently of the day by my interviewee. And I went up literally to an Ivy League university, very prepared, I thought, to take my interview to get into med school. And here I'm in my pre-med program and I've researched everything, I thought. And I walk into this clinic and they introduced me to this doctor who's probably in his 70s at that point, hunched over a desk, really focused on something. And she says, "Excuse me, sir." The secretary said, "You have an interview with you at Mr. Fetke's here." And he goes, "Oh, yeah, sorry, I forgot about that. Hold on, I'll be right with you." And he turns around, he goes, "Well, I'm supposed to ask you a question, right, young man?" And I said, Yeah." I'm thinking, "Yeah, that's what I'm here for," quietly to myself. And he says, "Well, here's a question. I'm sitting here with this piece of paper that's got a list of different diagnoses and procedures and codes, and it's all turned into numbers, and I have to check this thing off. And this is all new, and I'm trying to figure this out. They weren't doing it this way before, and I guess they're just trying to count the beans. But here's my question to you, young man. If they're trying to turn healthcare into a shopping list, why shouldn't I just quit right here and now? Convince me to stay."
Convince
Now,
me. A was your interview question.
That's my question, Dami asked my first interview. And I don't know what I answered. I don't remember. I was probably shocked and stunned. I hadn't prepared for that one. Um, Somehow I got out of it. I did answer, and it was literally, I walked out of there just completely in shock. And it stuck with me all these years, obviously. This is some 30 some years ago, this question was posed. And this system has gotten even more and more like that. It's become more encumbered. I think we have to answer, all of us have to answer that doctor who's probably no longer alive, but cared, obviously cared about this issue. I think we owe him and all of us an answer to that question. Why are we still pursuing that path when there's so much evidence that it's the wrong direction and it's not getting us to where we need to be?
What's your answer?
I think that the answer is to kind of in almost, dramatic fashion. I hate to say this, but literally, you know, for Jesus at the tables, knock the table over, throw it down, say, this is wrong. Come down and say, what is ethically the basis of what we're trying to do? Let's focus back on that patient care, our community care, our goal as a society. Let's define those. Actually, that's kind of how I finish in the book. I'm not trying to give away the punchline, but one of the questions I ask in this book is, what do we want? What is the goal? How do we define this before we start creating a system around healthcare and how we actually pay for and do that? Let's step back again and ask those basic questions. What are the fundamental value systems that we want as a people, as a society, as communities? I think that's the answer. Let's get back to those basics and rebuild the system around those values. And you will find that a lot of the things that we now have in it don't belong. And be very clear, just like you're trying to clean your house for any other reason. Do I really need this? Is this really helping perpetuate and improve care? Is it part of the picture of that value that I've decided, or is it extraneous? And is it taking away perhaps from what I'm trying to do? I know this sounds like a very broad answer, but I think it's a very down to basic core value infrastructure question. What is it that Americans want out of their healthcare system? Where are we going? Define that path and then create a plan. We can do this. We've done amazing things in our society. The world looks to us and says, America, you've been there before. You've achieved things in so many ways that other countries have been amazed about and now join you on. And we don't have to be alone doing this, by the way. We can share this with others, look at other models and see what works and doesn't, but adapt it to our own value system. That's where I would begin. Answer those basic questions first, because I think we're way astray from that.
Do you see the high price of healthcare either as evidence of not having defined the values, or the values having been subtly defined by people who are benefiting from
Yeah.
the
Yeah.
rising prices?
I think that the value system that the economics of healthcare currently represent and portray are not in line with the values of the healthcare system that I would envision. And many of the people I've talked to and who have been policymakers would envision. I'm not against capitalism. Don't get me wrong. I think there's a lot of benefit to incentivizing, to competition, to making people want to be rewarded for putting in sweat equity and work and doing something that helps other people. I'm against it just for its own sake, but I'm not sure that that model applies to healthcare, because what happens when you do that, the two are at odds constantly. You're more interested, and what happens is people are more interested in what the shareholder will make or the profit value out of this, or how much you can cut out some of the expenses, and you're focusing more on the widgets than what you're trying to actually make out of the widgets. And so you're selling these widgets, you're selling these tools, you're selling these medications, and people are coming in and going, hey, this is a good market. I want a piece of that action. And so I think that our value systems of our capitalist form of way of life and the healthcare model economics, they don't work very well. I think you can bring them side by side in parallel, but I think that you have to hold on to the healthcare model and economics and how you pay for that in a way that is sort of resilient and resistant to some of the forces of the capitalist system that will detract you from going where you should be going. And who determines that? The society, public, physicians, clinicians, and public as whole, all of us who have a stake. We have to decide, what are we trying to buy here? And when we're trying to buy things to just treat, and somebody is making money on the side, they're not going to want to let go of that system. And all of a sudden you're away from health and you're more into wealth. And I think that's a problem.
When did it turn? When did the incentives turn?
Well, we talk about this, and I even opened up some of the original discussions in the first podcast episode almost 3 years ago now. It turned when we came out of the Great Depression. We literally had a question of how we're going to get the people who are coming out of this and needing to be employed back into the employment sector, bring the economy back up, the New Deal, the whole bit. How do we revitalize this economy after the Great Depression? And, the answer was, well, health has to be a part of this. We have to make sure that the employees see a reason to want to go to a certain employer by tying the employment somehow to their employment. And that's what eventually happened. What we first started doing was saying, we're going to, as a nation, make sure that everybody has at least some standard of health care. And so what we did is we literally created Blue Cross Blue Shield. The historic foundation of Blue Cross Blue Shield was, as much as any system, a socialized system. It was an equal, equitable system that everyone could afford and access. And literally, if we don't have this image as a sense of, something that was equitable, we had the Boy Scouts of all people selling it to people door to door. They literally were knocking on the door saying, hi, there's this system, and in order to help you pick yourself back up, this is what your government, your community is trying to do. Here's Blue Cross Blue Shield. Well, what happened was that people saw that as a money-making system. It was a nonprofit system initially, and it wasn't tied to employment. But the employers turned around and said, could I use that to incentivize getting employees? Could I say, hey, I will provide insurance to you as part of the package, not just your salary and not just housing and other benefits, but I'm going to provide healthcare to you as part of your package. And I'll take care of all the paperwork. I'll do it all. Just come and join us, and you'll tell your family, look, hon, this is what I got with the job. I got all this. Once we started attaching the healthcare to the employment model, then the money started ringing, because people not only were looking at it from a job incentive, but then other insurance companies said, I can then create a system to those employers, and I can create some way of creating a profit generating system that kind of looks like, but competes with Blue Cross Blue Shield, which is a little more expensive. I'll kind of underprice that, and I'll beat out Blue Cross Blue Shield, give that to the employer, who will then turn to their potential employees and attract them. And we'll create this system. Well, the reason that Blue Cross Blue Shield, when it was a nonprofit system, costs more was because it essentially covered more. Soon enough, those people who are trying to outdo and make a profit-based system and are making money doing this under the capitalist model, they're realizing, there's a reason that it wasn't making money. This is a hard thing to do. It's not like other businesses. The business model doesn't work. We're going to have to do something. We're going to have to raise the price of the actual, what people are paying for the healthcare, or the employer contributes, or we're going to have to exclude certain things so that we don't go broke, because we can't give away the house. We want to make a profit here. And once that whole model changed, off the train ran. And ever since then, we've been trying to take that tiger by the tail and bring it back in some form. And we just haven't been able to do it. So much of this has morphed into all these different versions, capitalization of systems and HMOs and all these alphabet soup of things that just look so complicated. It literally makes the tax code look simple. And it really has overwhelmed everyone. And we've turned it into this beast.
It's fascinating. Once you put a monetary value on healthcare implicitly through attaching it to employment, the cat is kind of out the bag, and
Yeah.
the genie's out the bottle, and it's been very difficult to bring it back in. Just to finish, are you hopeful about the hunger and the policy power to start addressing high prices?
I think I'm always optimistic as a pediatrician. A fresh start every time I see a new patient, a new person who not only I can care for, but hopefully teach them to care for themselves, kind of the mold, and then have students around me so I can show them, look, this is how the healthcare system advances one by one, but also at a policy level. We have to think both of what's happening in the office, in the community, and the nation at large. I think I'm hopeful because I see my students and some of my patients interested in policy and advocacy for the first time. This is a big part of what they do. I think people have suffered enough under the system. A few years ago in campaigns, presidential campaigns, you'd literally have people saying, potential candidates saying, hey, what's wrong with the system? Everybody likes this system. What are you talking about? To people who are proposing other more universal models. And I don't think people can say that clearly anymore. I don't think people would, be taken seriously as they were maybe a decade ago saying something like that. Literally, it's almost like the environment. The environment's fine. What are you talking about? Nobody says that anymore. I think they can't say that anymore about our healthcare and our insurance system and the way we're funding this. Are there people who are happy? Sure. There are an upper echelon and people who are very, very, very lucky who are getting that. There may be people even on the lower echelon socioeconomically who are getting more than they ever planned to get. But that middle core, that bulk of this is not happy. And I think that's where this is and should be driven. It should be driven by the middle class. I think that's where the economics comes in and the politics. It's a question of what does the populace want? And I see them more engaged than ever and more willing to consider other models than ever now that they've suffered personally, seen other family members do so, or see what it's doing to the bottom line of our nation, that healthcare, as the prior administrations were concerned about with the Affordable Care Act, healthcare is a huge part of our economics and it affects all of us in some capacity. They're starting to realize if we help everyone have some basic model of care again, like the old Blue Cross Blue Shield model, maybe there was something to that, and we all can win in so many ways in health and economically. I think this dynamic, and I'm hoping this dynamic is something that's becoming part of the public discourse, the kitchen table discussion. Yes.
Dr. Fethke, thank you for being here.
Oh, my honor. And I'm always excited about talking about this and the more people that we can get engaged into it. I don't want people to feel, as you know, Jamie, I don't want people to feel like this is not a discussion that belongs to them or it's above their head or too complex. I think all of us have to kind of put our foot in this water and it will work when we do it together. People who are not in healthcare have just as much to contribute as those who are.
Dr. Fethke, until next time.
All right. Stay well, Jamie. Thank you.